Picture this. A young woman in pristine scrubs walks through the automatic doors of City General Hospital, carrying a simple canvas bag and wearing the kind of quiet confidence that comes from facing life and death situations. The nursing staff barely glances up from their gossip session, too busy discussing weekend plans to notice the new hire. What they see is just another fresh graduate, probably naive enough to think she can change things around here. What they don't see is the combat medic who spent 3 tours in Afghanistan, the woman who performed emergency surgery in the back of a moving Humvee while under enemy fire, the soldier who earned a Bronze Star for saving lives when others ran for cover. This is the story of how one nurse's hidden past turned a toxic workplace upside down and reminded everyone what real strength looks like. Before we jump back in, tell us where you're tuning in from, and if this story touches you, make sure you're subscribed, because tomorrow I've saved something extra special for you. The morning fog hung low over downtown Seattle as Sarah Mitchell pulled her Honda Civic into the employee parking garage of City General Hospital. At 29, she possessed an understated presence that people often overlooked at first glance. Her auburn hair was pulled back in a practical ponytail, and her green eyes held a steadiness that spoke of experiences far beyond her years. She wore navy blue scrubs that were crisp and new, with comfortable sneakers that showed she understood the demands of 12-hour shifts on her feet. What wasn't visible was the disciplined posture of someone trained to move efficiently under pressure, or the way her eyes automatically scanned for exits and potential threats, habits ingrained during her military service. City General Hospital stood as one of Seattle's largest medical facilities, a sprawling complex that served over 500,000 patients annually. The 20-story building housed everything from a Level 1 trauma center to specialized cardiac units, and its reputation for excellence drew medical professionals from across the Pacific Northwest. However, like many large institutions, it had developed its own internal culture, complete with hierarchies, cliques, and unfortunately, a tolerance for workplace dysfunction that administrators preferred to ignore rather than address. Sarah had been hired for the emergency department, a high-stress environment where quick thinking and calm under pressure were essential. She'd chosen emergency nursing specifically because it reminded her of the intensity and purpose she'd found as a combat medic. After struggling to adjust to civilian life for nearly 2 years following her discharge, she'd finally found a path that felt meaningful. Her military experience had given her medical skills that far exceeded what most nursing programs taught, but she'd kept that background minimal on her resume, mentioning only her service without elaborating on her role or achievements. The hiring process had been surprisingly smooth. Nurse manager Patricia Williams had been impressed by Sarah's test scores and clinical knowledge, though she'd seemed curious about the gap in Sarah's work history. Sarah had explained simply that she'd served in the military and was now ready to transition into civilian healthcare. Patricia had nodded approvingly, mentioning that they could use someone with discipline and reliability in the department. What Patricia didn't know was that Sarah had commanded a medical team of 8 soldiers, had been decorated for valor under fire, and had developed a reputation among special forces units for being the medic they requested when missions went sideways. As Sarah walked through the hospital's main entrance that first Monday morning, she took in the familiar sights and sounds of a major medical center. The scent of antiseptic mixed with coffee from the lobby cafe, overhead pages called for various doctors and codes, and the steady flow of patients, families, and staff created the controlled chaos she remembered from field hospitals. She felt a sense of coming home, of finding a place where her skills and experience could serve a meaningful purpose again. The emergency department occupied the entire first floor of the hospital's east wing. Double doors marked "Authorized" personnel only separated the treatment area from the public waiting room, and Sarah badged herself in for the first time, feeling a small thrill of belonging. The department was laid out efficiently, with a central nurses' station surrounded by treatment rooms, trauma bays, and specialized areas for different types of emergencies. Even at 7 in the morning, the pace was already picking up as the day shift took over from the exhausted night crew. Sarah reported to the charge nurse's desk, where she was greeted by Patricia Williams, a woman in her early 50s with graying hair and kind eyes that had seen decades of medical emergencies. Patricia had been at City General for over 20 years and had earned respect through her clinical expertise and fair leadership style. She was one of the few managers who genuinely cared about her staff's well-being and professional development. "Sarah, welcome to the chaos," Patricia said with a warm smile. "I know orientation can be overwhelming, but you'll catch on quickly. The morning shift is usually our busiest, so you'll get thrown into the deep end pretty fast." She handed Sarah a badge clip and a packet of paperwork. "I've paired you with Jennifer Martinez for your first week. She's one of our senior nurses and she'll show you our protocols and procedures." Jennifer Martinez appeared a few minutes later, a woman in her mid-30s with dark hair and an efficient manner that spoke of years of emergency medicine experience. She had the no-nonsense attitude that Sarah appreciated, someone who focused on getting things done rather than office politics. Jennifer's reputation in the department was solid. She was known for her clinical skills, her ability to handle difficult patients, and her willingness to mentor new staff. "So you're the new recruit," Jennifer said, extending her hand. "Patricia mentioned you have some medical background beyond nursing school." "Military?" "Army," Sarah replied simply. "Combat medic for about 6 years." Jennifer's eyebrows rose. "Slightly. Well, that's definitely more than most of us have seen. Should be an interesting transition. Emergency nursing is different from field medicine, but a lot of the pressure management skills transfer over." She gestured for Sarah to follow her. "Let me show you around and introduce you to the team." The tour began with the practical basics: supply rooms, medication storage, computer systems, and communication protocols. Jennifer explained the department's patient flow, from triage through discharge, and outlined the different roles each team member played. Sarah absorbed the information quickly, asking thoughtful questions that showed she understood both the clinical and operational aspects of emergency care. "Most new nurses take weeks to feel comfortable with our charting system," Jennifer noted, as Sarah navigated the electronic medical records with ease. "You're picking this up fast." "I'm used to adapting to new systems quickly," Sarah replied. "In the military, you learn to figure things out on the fly because lives depend on it." As they moved through the department, Jennifer introduced Sarah to various staff members. The day shift team included about 15 nurses, several emergency medicine residents, attending physicians, technicians, and support staff. Most people were friendly but busy, offering quick hellos before returning to their patient care responsibilities. The atmosphere was professional and focused, exactly what Sarah had hoped for. However, as they approached the central nurses' station, Sarah noticed a shift in Jennifer's demeanor. Her mentor's jaw tightened slightly, and she lowered her voice. "There's something you should know about the dynamics here. Most of the staff are great to work with, but there's a group that can be challenging. They've been here a long time and they have strong opinions about how things should be done." And before Jennifer could elaborate, 3 nurses looked up from their conversation at the station. The apparent leader was Victoria Chen, a woman in her early 40s with perfectly styled black hair and scrubs that somehow managed to look designer despite being standard hospital issue. She had been at City General for 12 years and had cultivated a position of informal authority through a combination of clinical knowledge, political maneuvering, and strategic alliances with certain physicians. Victoria's smile as she approached was polite, but didn't reach her eyes. "You must be the new nurse Patricia hired," Victoria said, her tone professionally friendly, but with an undertone that suggested evaluation. "I'm Victoria Chen, one of the senior staff here. We heard you're coming from..." Preparing and narrating this story took us a lot of time, so if you are enjoying it, subscribe to our channel. It means a lot to us. Now back to the story. "A different background?" "Sarah Mitchell," Sarah replied, extending her hand. "Yes, I'm transitioning from military service, looking forward to working with everyone." Victoria's handshake was brief and formal. "Military? That's interesting. Well, you'll find that hospital protocols are quite different from whatever you might be used to. We have very specific ways of doing things here, and patient safety depends on everyone following established procedures exactly." The implication was clear. Don't come in here thinking your outside experience makes you special. Sarah simply nodded, recognizing the territorial marking for what it was. She'd encountered similar dynamics in the military when transferring between units. Standing behind Victoria were her two closest allies in the department. Rebecca Stone was a nurse in her late 30s who had developed a reputation for sharp comments and passive-aggressive behavior toward anyone she perceived as a threat to the established order. She was technically competent, but used her knowledge as a weapon, often making newer staff feel incompetent through subtle criticism and exclusion. Michael Torres, the only male nurse in their clique, was in his early 30s and had perfected the art of workplace manipulation. He was charming when it served his purposes, but could turn cruel without warning, particularly towards staff he saw as vulnerable. "Sarah will be shadowing Jennifer this week," Victoria continued, "but I'm sure we'll all have opportunities to share our knowledge. This department has very high standards, and we take pride in maintaining them." The message was unmistakable. Step out of line, and there would be consequences. Jennifer quickly steered Sarah away from the group, citing the need to review emergency protocols. As they walked toward the trauma bays, she spoke quietly. "Victoria runs what I call the Mean Girls Club. They've made life miserable for several nurses over the years. Some have transferred departments, others have left the hospital entirely. Administration knows about it, but tends to look the other way because they're clinically competent, and Victoria has connections with some of the attending physicians." Sarah absorbed this information without comment. She'd seen similar dynamics in military units, informal power structures that could be more influential than official chains of command. The key was understanding the terrain before making any moves. The rest of the morning passed smoothly as Sarah observed patient care procedures and began to understand the rhythm of the emergency department. She watched Jennifer handle a variety of cases: a heart attack patient, a child with a broken arm, an elderly woman with difficulty breathing, and a construction worker with a deep laceration. Sarah found herself impressed by the clinical expertise and teamwork when staff were focused on patient care rather than office politics. During their lunch break, Jennifer provided more context about the department's history. Victoria's group gained influence about 5 years ago when the previous charge nurse retired. Patricia is technically in charge, but Victoria has been here longer and has built relationships with key physicians. She's very good at making herself indispensable while undermining anyone she sees as competition. "What about administration?" Sarah asked. "Don't they address workplace issues?" Jennifer laughed bitterly. "City General is more concerned with metrics and patient satisfaction scores than staff morale. As long as the numbers look good and there are no lawsuits, they prefer to let departments handle their own problems. Victoria's smart enough to never do anything that could be documented as harassment. It's all very subtle. Exclusion from important communications, assignment to the worst shifts, isolation from social activities, death by 1,000 cuts." Sarah nodded, understanding the dynamic. She'd seen similar patterns in military units. where toxic leaders were protected because they produced results, regardless of how they treated their subordinates. The difference was that in the military there were eventually consequences when toxic leadership affected unit cohesion and mission effectiveness. Civilian workplaces often had fewer accountability mechanisms. The afternoon brought Sarah's first real test. She was assigned to assist with a multi-vehicle accident that brought in 4 patients simultaneously. The trauma bay erupted into controlled chaos as teams worked to stabilize the injured. Sarah found herself working alongside Victoria on a patient with multiple fractures and internal bleeding. Despite her personal reservations about Victoria's leadership style, Sarah had to admit the woman was clinically excellent, quickly assessing the patient's condition and coordinating care with the trauma surgeon. However, Victoria seemed determined to test Sarah's competence under pressure. She fired rapid questions about medications, dosages, and procedures, clearly expecting the new nurse to stumble. Instead, Sarah answered confidently and accurately, drawing on her extensive field experience. When Victoria requested specific equipment, Sarah had already anticipated the need and had it ready. When the patient's blood pressure dropped suddenly, Sarah noticed the change in the monitor before Victoria and had already begun adjusting the IV fluids. "You seem very comfortable with trauma cases," Victoria commented after the patient was stabilized and transferred to surgery. Her tone was neutral, but Sarah detected surprise and perhaps a hint of concern. "I've seen my share of traumatic injuries," Sarah replied simply. "Different setting, but the principles of trauma care are pretty universal." Victoria studied her for a moment, then nodded curtly before moving on to her next patient. Sarah sensed that she'd passed some kind of test, but also that Victoria now saw her as a potential threat to the established hierarchy. The next few days followed a similar pattern. Sarah proved herself clinically capable, often demonstrating knowledge and skills that exceeded what was expected from a new nurse. She remained professional and focused on patient care, but she couldn't help noticing the subtle dynamics that Jennifer had warned her about. Victoria's group had their own communication channels, sharing information and opportunities while excluding others. They had first choice on scheduling preferences, were invited to social events that others weren't, and received informal mentoring that could advance careers. More concerning was how they treated staff they'd marked as targets. Sarah watched Rebecca make cutting comments about a young nurse's clinical judgment in front of patients and families. She observed Michael forget to pass along important information to nurses he disliked, creating potential safety issues. Victoria herself was more subtle but perhaps more dangerous, using her influence with physicians to undermine staff she wanted to eliminate. The breaking point came on Sarah's 5th day during the particularly busy Friday evening shift. The department was dealing with the usual weekend influx: car accidents, bar fights, drug overdoses, and various other emergencies that seemed to multiply after dark. Sarah had been assigned to work with a newer nurse named Amy Peterson, a recent graduate who was still learning the ropes. Amy was eager and competent, but lacked confidence, making her an easy target for Victoria's group. Sarah was in the supply room restocking her assigned trauma bay when she heard raised voices from the central station. Through the partially open door, she could see Victoria confronting Amy about a medication error that had been caught before it could harm the patient. While the error needed to be addressed, Victoria's approach was unprofessional and humiliating. "This is exactly the kind of careless mistake that could kill someone," Victoria said loudly enough for other staff and patients to hear. "I don't understand how you got through nursing school without learning basic medication safety. Maybe emergency nursing isn't for you." Amy's face flushed red as she tried to explain that she'd been interrupted while preparing the medication, but Victoria cut her off. Excuses don't save lives. Competence does. I'm going to have to document this incident and recommend additional training. Sarah could see that Amy was close to tears, and several other staff members looked uncomfortable, but unwilling to intervene. This was exactly the kind of public humiliation that Victoria used to establish dominance and drive out nurses she didn't want in the department. Rebecca appeared as if on cue, adding her own criticism. We've all noticed that you struggle with time management, Amy. Emergency nursing requires quick decision-making and accurate execution. Maybe you should consider a slower-paced environment like medical surgical nursing. The attack was coordinated and vicious, designed to destroy Amy's confidence and reputation in front of her colleagues. Sarah recognized the tactic: isolate the target, attack their competence publicly, and make them doubt their own abilities. It was psychological warfare disguised as professional feedback. Sarah made a decision. Setting down her supply inventory, she walked out of the supply room and approached the group at the nurses' station. Her movement was calm and deliberate, the kind of presence she'd developed when dealing with dangerous situations that required careful handling. "Is there a problem here?" Sarah asked in a neutral tone, directing her question to Amy rather than Victoria. Victoria's eyes flashed with irritation at the interruption. "This doesn't concern you, Sarah. We're addressing a medication error with Amy." Sarah looked at Amy, whose hands were shaking slightly as she clutched a patient chart. "Amy, what happened?" Amy glanced nervously between Sarah and Victoria before explaining. "I was preparing morphine for the patient in bed 7 when Dr. Matthews called me over to assist with an intubation. When I came back, I couldn't remember if I'd drawn up the correct dose, so I started over to be safe. Victoria says I should have remembered exactly where I was in the process." Sarah nodded thoughtfully. "So you followed proper safety protocol when you were unsure. You discarded the medication and started fresh rather than guessing. That's exactly what you should have done." Victoria's face hardened. The error was in letting herself be distracted in the first place. Medication preparation requires complete focus. "You're right that focus is important," Sarah agreed. "But in an emergency department, interruptions are inevitable. The safety protocols exist precisely because we know distractions will happen." Amy did exactly what she was trained to do when faced with uncertainty. The logic was unassailable, and Victoria knew it. The medication error she'd been describing wasn't actually an error at all. It was a nurse following safety protocols appropriately. Victoria had been trying to create a problem where none existed, using Amy's inexperience and lack of confidence against her. Rebecca jumped in to support her ally. "New nurses need to learn to manage multiple priorities. In a year, Amy will need to handle much more complex situations." "That's what training and experience are for," Sarah replied calmly. "Amy's been here 3 weeks. She's learning, and today she demonstrated good judgment under pressure. That should be encouraged, not criticized." The tension in the air was palpable. Other staff members had slowed their activities to watch the confrontation, sensing that something significant was happening. Victoria's authority was being challenged, but in a way that couldn't be dismissed as insubordination or unprofessional behavior. Sarah was defending appropriate clinical practice and supporting a newer nurse. Exactly what a good mentor should do. Victoria regrouped quickly, switching tactics. "Sarah, I appreciate your desire to support your colleagues, but you're still very new here yourself. There are dynamics and history that you don't understand yet. Amy has had several issues with attention to detail, and this is part of a pattern we need to address." It was a skillful deflection, using Sarah's newcomer status to undermine her credibility while implying that Amy had a documented history of problems. Sarah recognized the manipulation, but also realized that pushing further in this public setting would escalate the conflict unnecessarily. I understand, Sarah said neutrally. Amy, do you feel comfortable continuing with your patient assignments, or would you like to review any protocols? Amy straightened slightly, some confidence returning to her voice. I'm comfortable with my assignments, thank you for asking. Sarah nodded and turned back to Victoria. If there are specific training needs or protocol clarifications Amy needs, I'm happy to work with her during the rest of the shift. It was a diplomatic solution that protected Amy while acknowledging Victoria's authority. Victoria couldn't object without appearing unreasonable, but she also couldn't continue her public humiliation campaign with Sarah present as a witness and advocate. That won't be necessary, Victoria said stiffly. Amy knows what's expected of her. As the group dispersed, Sarah caught Amy's grateful look and Victoria's calculating stare. She'd made an enemy today, but she'd also prevented a promising young nurse from being driven out of the profession by workplace bullying. It was a trade-off she was comfortable making. Jennifer approached Sarah a few minutes later as they prepared medications in the secure pharmacy area. That was brave, she said quietly, and probably foolish. Victoria doesn't forget challenges to her authority. Amy was following proper protocol, Sarah replied. Someone needed to point that out. You're right, but being right isn't always enough in this place. Victoria has ways of making life difficult for people she doesn't like. You might want to be extra careful about documenting everything you do for a while. Sarah nodded, understanding the warning. She'd made her position clear. She wouldn't stand by while competent staff were harassed and driven away. Now she had to be prepared for the consequences. The rest of the shift passed without incident, but Sarah could feel the shift in dynamics. Victoria's group was more subdued around her, their usual casual dominance tempered by uncertainty about how far she might be willing to push back. Other staff members seemed intrigued by the new nurse who'd stood up to Victoria without backing down or losing her temper. As Sarah gathered her belongings at the end of her shift, Patricia approached her near the lockers. I heard there was some tension today during the medication review. Sarah chose her words carefully. Amy followed appropriate safety protocols. When she was uncertain about a medication preparation, I supported her decision because it was the correct one clinically. Patricia studied her for a moment. Victoria mentioned that you might benefit from some guidance about department communication styles and team dynamics. I'm always open to feedback, Sarah replied honestly, but I won't compromise patient safety or stand by while good nurses are discouraged from following proper protocols. Patricia's expression was unreadable. This department functions on teamwork and mutual respect. I need to know that all my nurses can work together effectively. I agree completely, Sarah said. Effective teamwork requires that clinical decisions be based on evidence and best practices, not personality conflicts or power dynamics. It was a subtle but clear statement of her position. She would work collaboratively with anyone committed to excellent patient care, but she wouldn't enable workplace dysfunction that could compromise safety or drive away competent staff. Patricia nodded slowly. Keep me informed if you have any concerns about department operations or staff interactions. My door is always open. As Sarah drove home through the Seattle evening traffic, she reflected on her first week at City General. The clinical work was challenging and rewarding, exactly what she'd hoped to find in civilian healthcare. The department had excellent resources, skilled physicians, and most of the nursing staff were dedicated professionals who genuinely cared about their patients. The problem was the toxic subculture that Victoria had created, and the administration's apparent willingness to tolerate it as long as it didn't create legal liability or public relations problems. Sarah had seen similar dynamics in military units, where informal power structures undermined official leadership and damaged unit effectiveness. The difference was that Sarah was no longer a 19-year-old private trying to survive her first deployment. She was a combat veteran with leadership experience, advanced medical training, and a clear sense of her own values and capabilities. She'd faced down armed insurgents, treated casualties under fire, and led medical teams in situations where mistakes meant death. Victoria Chen and her clique might think they could intimidate or manipulate her the way they had other nurses, but they had no idea what they were dealing with. Sarah hadn't come to City General looking for a fight, but if one was forced on her, she was more than prepared to handle it. The question was how far Victoria would be willing to push, and how much support Sarah could count on from other staff who were tired of the toxic environment but afraid to speak up. Change was possible, but it would require courage from people who had learned to keep their heads down and avoid becoming targets. As Sarah pulled into her apartment complex, she made a mental note to document today's interactions carefully. If Victoria wanted to play political games, Sarah would be ready. But unlike the bullies, who relied on intimidation and manipulation, Sarah's strength came from competence, integrity, and the kind of quiet confidence that could only be earned through facing real challenges and emerging stronger. Tomorrow would bring new patience, new challenges, and undoubtedly new tests of her resolve. But tonight, Sarah felt something she hadn't experienced since leaving the military, a sense of purpose and belonging. She was exactly where she needed to be, doing work that mattered, with the skills and experience to make a real difference. Victoria's group might have controlled the department through fear and manipulation for years, but they'd never faced anyone like Sarah Mitchell. The combat medic who'd saved lives under fire wasn't about to be intimidated by workplace politics and petty power games. The real battle was just beginning. Sarah's second week at City General began with an ominous shift in atmosphere. Victoria's group had clearly regrouped after the medication incident, and their strategy had evolved from testing boundaries to active undermining. The change was subtle, but unmistakable to someone trained in reading hostile environments. The first sign came during Monday morning report, when the night shift charge nurse handed over patient assignments. Sarah found herself scheduled for the most demanding cases with minimal support staff, while Victoria's allies received lighter loads and additional help. When Sarah questioned the assignment distribution with Patricia, she was told that senior nurses received preferential scheduling based on experience and department needs. The second warning came in the form of missing supplies. Equipment Sarah requisitioned would disappear from her assigned trauma bays, forcing her to hunt down replacements while patients waited. Medications she'd ordered would be marked as unavailable, requiring time-consuming pharmacy calls to verify stock levels. The delays were minor individually, but accumulated into a pattern of inefficiency that could be documented as performance issues. Victoria's psychological warfare campaign was sophisticated and calculated. She began scheduling impromptu staff meetings during Sarah's breaks, ensuring she missed important communications about policy changes and procedure updates. She reassigned Sarah's parking space to a distant section of the garage, claiming seniority privileges. She excluded Sarah from informal mentoring sessions where senior nurses shared clinical tips and department politics. Most insidiously, Victoria began questioning Sarah's clinical decisions in front of physicians and other staff. When Sarah recommended pain medication for a patient with obvious discomfort, Victoria would suggest that a more experienced nurse might want to assess the situation first. When Sarah identified subtle changes in patient status, Victoria would imply that newer nurses sometimes overreacted to normal variations. The attacks were professionally phrased and technically within acceptable bounds of peer review, but their cumulative effect was clear, established doubt about Sarah's judgment and competence. Other staff members who might have been inclined to support Sarah began to question whether the conflict was worth getting involved in, especially when it might jeopardize their own standing in the department. Rebecca and Michael provided tactical support for Victoria's campaign. Rebecca specialized in spreading subtle rumors and casting doubt on Sarah's qualifications. She would mention in casual conversations that she'd heard Sarah's military experience might not translate well to civilian healthcare, or that combat medics sometimes struggled with hospital protocols. Michael focused on social isolation, organizing after-work gatherings and department celebrations while ensuring Sarah wasn't invited. The strategy was working on multiple levels. Sarah's patient assignment load was heavier and more complex, creating legitimate stress and fatigue. Her access to informal support networks was being systematically cut off. Her professional reputation was being undermined through calculated doubt casting and exclusion from key communications. Jennifer watched the campaign with growing concern, but her attempts to provide support were limited by her own vulnerability. As a single mother with financial obligations, she couldn't afford to alienate Victoria's group and risk her own job security. She offered what help she could discreetly, sharing information about department policies and covering for Sarah when possible. But she made it clear that she couldn't openly challenge the established power structure. Other nurses in the department fell into predictable categories. Some actively supported Victoria either from genuine loyalty or calculated self-interest. Others disapproved of the harassment but felt powerless to intervene without becoming targets themselves. A few newcomers, like Amy, looked to Sarah for protection, but lacked the seniority or confidence to provide meaningful support in return. Sarah documented everything meticulously, maintaining detailed records of scheduling irregularities, supply shortages, communication exclusions, and inappropriate challenges to her clinical judgment. Her military training had taught her the importance of maintaining accurate records when dealing with hostile leadership, and she suspected she would need comprehensive documentation before the situation resolved. What Victoria's group didn't understand was that their campaign of attrition was actually playing to Sarah's strengths rather than exposing weaknesses. The heavier patient loads forced her to work more efficiently, highlighting her superior time management and clinical skills. The isolation from department politics allowed her to focus entirely on patient care, earning recognition from physicians who valued competence over social maneuvering. Most importantly, the constant low-level stress was familiar territory for someone who'd operated in combat zones where genuine threats were a daily reality. Workplace harassment from civilian nurses seemed manageable compared to treating casualties while under sniper fire or dealing with improvised explosive devices that could detonate without warning. Sarah's breaking point wasn't reached through accumulated harassment, but through a deliberate escalation that threatened patient safety. The incident occurred during a particularly busy Thursday evening shift when the department was dealing with multiple trauma cases from a construction accident. Sarah was assigned to assist with a patient who'd fallen 3 stories and sustained multiple injuries, including a suspected spinal fracture. The patient, Marcus Thompson, was a 34-year-old construction foreman who'd been conscious and alert when paramedics arrived, but had developed concerning neurological symptoms during transport. Sarah recognized the signs of potential spinal cord compression, a medical emergency that required immediate intervention to prevent permanent paralysis. As Sarah worked to stabilize Marcus and prepare him for emergency imaging, Victoria appeared at the trauma bay with Dr. Harrison Wells, one of the emergency medicine residents who had a reputation for being easily influenced by senior nursing staff. Victoria's timing wasn't coincidental. She'd been waiting for an opportunity to challenge Sarah's clinical judgment in a high-stakes situation where the consequences of being wrong could be severe. Dr. Wells, Victoria said in her professionally concerned tone. I wanted to discuss the treatment plan for this patient. Sarah is recommending an immediate CT scan and neurosurgery consult, but I'm wondering if we might be overreacting to what could be normal post-trauma confusion. Dr. Wells, tired from a long shift and dealing with multiple critical patients, looked at Sarah expectantly. What are your concerns about the patient's neurological status? Sarah maintained her professional composure despite recognizing the trap being set. The patient was alert and oriented during initial assessment by paramedics, but he's now showing decreased sensation in his lower extremities and reporting severe neck pain that's disproportionate to his other injuries. His reflexes are diminished bilaterally and he's developing weakness in his hands. These findings are consistent with cervical spine injury with potential cord compression. Victoria smiled sympathetically at Dr. Wells. Those symptoms could also be explained by pain, medication effects, general trauma response, or anxiety about his injuries. Sarah's military background might be influencing her to see more serious conditions than actually exist. Combat medics are trained to assume worst-case scenarios, which isn't always appropriate in a hospital setting. The comment was expertly crafted to undermine Sarah's assessment while appearing to show understanding of her background. It suggested that her military experience was a liability rather than an asset, implying that she couldn't distinguish between battlefield medicine and civilian healthcare. Dr. Wells hesitated, clearly influenced by Victoria's seniority and reputation in the department. What would you recommend, Victoria? I think we should observe the patient for another hour while administering pain medication and see if his symptoms improve. If he's still showing concerning signs after we've addressed his pain and anxiety, we can reassess the need for immediate imaging. Sarah felt her pulse quicken as she recognized the dangerous path Victoria was suggesting. Delaying imaging for a patient with potential spinal cord compression could result in permanent disability or death. Every minute of delay increased the risk of irreversible damage. Dr. Wells, Sarah said firmly, with respect to Victoria's experience, the constellation of symptoms I'm observing requires immediate evaluation. The patient's neurological changes aren't consistent with medication effects or anxiety responses. They're progressive and specific to spinal cord function. Victoria's expression hardened slightly. Sarah, I appreciate your concern, but you're still learning our protocols here. Dr. Wells has been managing emergency cases for years, and he's perfectly capable of making clinical decisions without pressure from newer staff members. The dynamics were clear to everyone in the trauma bay. Victoria was using her seniority and political influence to override Sarah's clinical assessment, despite Sarah's superior experience with traumatic injuries. Dr. Wells was being forced to choose between the recommendations of an established senior nurse and a newcomer who might know more about trauma medicine but lacked departmental standing. Marcus Thompson, still conscious despite his injuries, had been listening to the discussion with growing alarm. "Excuse me," he said weakly, "but I can't feel my legs anymore. Something's really wrong." The patient's deteriorating condition should have ended the debate immediately, but Victoria doubled down on her position. Pain and anxiety can cause temporary sensory changes, she told Dr. Wells. We shouldn't make hasty decisions based on subjective symptoms that could resolve with appropriate pain management. Sarah made a decision that would change everything. She stepped closer to Dr. Wells, her voice carrying the authority of someone who'd made life and death decisions under pressure. "Doctor, this patient has a progressing spinal cord injury. Every minute we delay imaging and intervention increases his risk of permanent paralysis. I've treated dozens of similar cases in combat situations, and this presentation is classic for cervical spine compression." Her tone was respectful, but absolutely certain. the voice of someone stating medical facts rather than offering opinions. Dr. Wells looked between the two nurses, suddenly aware that he was dealing with a genuine disagreement about patient care, rather than a simple personality conflict. Victoria realized she was losing control of the situation and made a critical error. "Sarah, your military experience doesn't make you more qualified than our established protocols. You're overstepping your role as a new nurse, and you're creating unnecessary anxiety for the patient and his family." The accusation was delivered in front of multiple witnesses, including other nurses, technicians, and Marcus Thompson himself. Victoria had essentially accused Sarah of practicing beyond her scope and creating problems through inexperience and poor judgment. Sarah's response was measured but unmistakable. She turned to address Dr. Wells directly, ignoring Victoria completely. "Doctor, I'm requesting that you document in the medical record that I recommended immediate imaging for this patient based on clinical findings consistent with spinal cord compression. I'm also requesting that my assessment be noted in case this patient develops permanent neurological deficits due to delayed treatment." The formal request for documentation changed the entire dynamic. Sarah was no longer simply advocating for a patient. She was creating a paper trail that would protect her professionally, while highlighting the potential consequences of ignoring her recommendation. If Marcus Thompson ended up paralyzed due to delayed treatment, the medical record would show that Sarah had identified the problem and recommended appropriate intervention. Dr. Wells suddenly understood the stakes involved. This wasn't about department politics or nursing hierarchy. It was about patient safety and legal liability. If Sarah was right about the spinal injury and he delayed treatment based on Victoria's recommendation, he could face serious professional consequences. "Let's get the CT scan now," Dr. Wells decided, and paged neurosurgery for a consultation. Victoria's face flushed with anger and humiliation. She'd been publicly overruled by a new nurse, and her medical judgment had been questioned in front of colleagues and a patient. Worse, if Sarah's assessment proved correct, Victoria would be seen as someone who'd endangered a patient to protect her ego and authority. The imaging results were available within 30 minutes and confirmed Sarah's clinical suspicions. Marcus Thompson had a displaced cervical vertebra creating pressure on his spinal cord. The neurosurgeon who responded to the consultation confirmed that immediate surgical intervention was required to prevent permanent paralysis. "Good catch on the spinal injury," Dr. Wells told Sarah as they prepared Marcus for emergency surgery. "His symptoms were subtle, but you picked up on the pattern. How did you know to look for cervical compression?" "I've seen similar presentations in blast injury cases," Sarah replied simply. The combination of mechanism and neurological changes was consistent with unstable cervical fracture. Word of the incident spread rapidly through the emergency department. Within hours, everyone knew that the new nurse had correctly diagnosed a critical condition that a senior nurse had dismissed, potentially saving a patient from permanent disability. The story grew with each telling, but the core facts remained consistent. Sarah's clinical expertise had been proven under pressure. Victoria's position was seriously undermined, but her response was to escalate rather than acknowledge the mistake. She spent the rest of the shift questioning Sarah's other clinical decisions, challenging her documentation and spreading the narrative that Sarah was a troublemaker who didn't respect department hierarchy. The campaign reached its peak the following Friday afternoon during the change of shift report. Sarah was presenting her patients to the incoming evening nurse when Victoria interrupted with a series of aggressive challenges about medication timing, documentation accuracy, and patient assessment findings. The attack was so obviously personal and unprofessional that other staff members stopped their own activities to watch. "I'm concerned about the number of judgment calls Sarah has been making independently," Victoria announced to the assembled nurses. New staff should be consulting with senior nurses before making significant clinical decisions. I think we need to implement closer supervision to ensure patient safety. The accusation was serious and public, effectively claiming that Sarah posed a risk to patients through inexperience and poor judgment. It was also completely unfounded, as Sarah's clinical performance had been exemplary, and her recent diagnosis of the spinal injury had demonstrated superior assessment skills. Sarah had reached her limit. The harassment had escalated from professional, undermining to direct accusations that could damage her career and reputation. More importantly, Victoria's behavior was creating a toxic environment that affected patient care and demoralized other staff members. Standing in the center of the nurses' station with the entire shift watching, Sarah made a decision that would change everything. She didn't raise her voice or lose her professional composure, but there was something in her posture and presence that commanded attention. "Victoria," Sarah said calmly, "I think we need to clarify something. You've been questioning my clinical judgment and suggesting that I need additional supervision. Let me share some context that might help you understand my qualifications." The room went silent as Sarah continued in the same measured tone. "I'm a combat veteran with 6 years of experience as a field medic in Afghanistan. I've performed emergency procedures under fire, managed mass casualty events with limited resources, and treated traumatic injuries that most civilian nurses never see. I've been decorated for medical excellence under combat conditions and have supervised medical teams in life and death situations." Victoria's confident expression began to waver as Sarah's credentials sank in. The other nurses listened with growing amazement as they realized they'd been working with someone whose experience far exceeded anything they'd imagined. "I've performed emergency surgery in the back of moving vehicles while under enemy fire," Sarah continued. "I've managed trauma cases where seconds meant the difference between life and death, with no backup support and limited supplies. I've trained Special Forces medics and been requested by name for high-risk missions because commanders trusted my medical judgment." The impact of these revelations was immediate and profound. Victoria had been presenting herself as the superior medical professional, but she'd never dealt with anything approaching the complexity and pressure of combat medicine. Her entire authority structure was based on department seniority and political maneuvering, not superior clinical expertise. "So when you question my ability to assess a cervical spine injury or suggest that I need supervision for basic emergency procedures," Sarah concluded, "I want you to understand that you're challenging someone who has more trauma experience than anyone else in this department. I didn't advertise my background because I believe in earning respect through current performance, not past achievements. But I won't allow you to undermine patient care or create a hostile work environment based on your need to maintain artificial authority." The silence that followed was electric with tension. Victoria stood frozen, her face cycling through emotions from shock to anger to something approaching fear. She'd built her power on intimidating nurses who couldn't or wouldn't fight back, but she'd never encountered someone with Sarah's background and confidence. Rebecca attempted to support her ally. Military experience doesn't automatically translate to civilian healthcare. Hospital protocols are different from battlefield medicine. Sarah turned to address Rebecca directly, her voice still calm but carrying an edge of steel. "You're absolutely right that protocols are different. In combat medicine, we work with minimal resources, no backup support, and life-threatening conditions that require immediate decision-making. Hospital medicine has better equipment, more staff, and established protocols for most situations. It's considerably less challenging from a clinical perspective." The implication was clear. If Sarah could excel in combat medicine's civilian Nursing was well within her capabilities. Rebecca's challenge had backfired, highlighting Sarah's superior experience rather than undermining it. Michael made his own attempt to regain control of the narrative. This sounds like you're trying to use your military service to intimidate civilian staff. We all respect veterans, but that doesn't mean you can ignore department hierarchy and team dynamics. Sarah's expression didn't change, but something in her eyes suggested that Michael had made a serious miscalculation. I'm not using my military service to intimidate anyone. I'm providing context for the clinical competence that Victoria has been questioning. As for department hierarchy, I respect legitimate authority based on medical expertise and patient care. I don't respect bullying disguised as professional oversight. The word bullying hung in the air like a challenge. Sarah had named the behavior that everyone recognized, but no one had been willing to address directly. Victoria's campaign of harassment was no longer hidden behind professional language and administrative cover. Dr. Wells, who had been listening from the edge of the group, stepped forward. "Sarah, I want to thank you again for your assessment of Mr. Thompson yesterday. The neurosurgeon confirmed that your early identification of the spinal injury was critical to preserving his neurological function. That kind of clinical judgment is exactly what we need in emergency medicine." The physician's public endorsement shifted the dynamic decisively. Victoria could challenge a new nurse's credibility, but she couldn't argue with a doctor's professional assessment based on patient outcomes. Patricia arrived at the nurse's station as the confrontation was reaching its climax. She'd been in administrative meetings for most of the day and was unaware of the escalating tensions. But the atmosphere in the department made it clear that something significant had occurred. "Is there a problem here?" Patricia asked, looking between Victoria and Sarah. Victoria quickly attempted to reframe the situation. "We were discussing clinical protocols and appropriate supervision for newer staff members. Sarah seems to feel that her previous experience exempts her from following our established procedures." Sarah's response was directed to Patricia, but clearly audible to everyone present. "Victoria has been systematically undermining my clinical decisions, questioning my competence in front of patients and colleagues, and creating a hostile work environment. When I correctly diagnosed a critical spinal injury that she wanted to dismiss, she escalated to public accusations about my judgment and patient safety. I've provided context about my medical background to clarify why her assessments of my competence are unfounded." Patricia looked around the room, taking in the expressions of the assembled staff. Some looked excited by the drama, others appeared uncomfortable with the conflict, and a few seemed relieved that someone had finally confronted Victoria's behavior directly. "I think we need to discuss this privately," Patricia said carefully. "Victoria, Sarah, my office in 15 minutes. Easy." As the group dispersed, Sarah could feel the shift in department dynamics. Some staff members avoided eye contact, uncertain about how the power structure would settle. Others approached with expressions of respect and curiosity, clearly impressed by her military background and willingness to stand up to Victoria. Amy stopped by Sarah's workstation as she finished her documentation. "I just wanted to say thank you," she said quietly. "Not just for standing up to Victoria, but for showing us that someone with real experience thinks we can do this job well. I've been doubting myself since I started here, but watching how you handle patience and pressure makes me think I might actually have what it takes." Jennifer appeared a few minutes later with a similar message. "I've wanted to confront Victoria's group for years, but I couldn't risk my job with my daughter's expenses. Watching you handle that situation showed me what real professional courage looks like." Even some of the physicians made comments about Sarah's military service and clinical expertise. Dr. Martinez, one of the senior emergency medicine attendings, stopped by to express interest in her combat experience and ask about differences between military and civilian trauma care. The meeting in Patricia's office was tense but professional. Victoria attempted to maintain her narrative about departmental hierarchy and appropriate supervision, but her argument seemed hollow after Sarah's public revelation of her background. Patricia, faced with clear evidence of workplace harassment and a high-performing nurse who'd already demonstrated superior clinical judgment, had little choice but to address the situation directly. "Victoria," Patricia said finally, "I'm concerned about the pattern of behavior that Sarah has described. Regardless of department seniority, we can't have nurses undermining each other's clinical assessments or creating hostile work environments. Sarah's performance has been exemplary, and her military experience is clearly an asset to our department." Victoria's face flushed with anger and humiliation. "So we're going to ignore years of dedicated service and department leadership because someone claims military experience trumps hospital protocols? We're going to ensure that all our nurses can work in a professional environment free from harassment and intimidation," Patricia replied firmly. "That applies to everyone, regardless of seniority or background." The resolution was clear. Victoria's campaign against Sarah was officially over, and any further harassment would face formal disciplinary action. Victoria accepted the decision with ill grace, her authority in the department permanently damaged by the confrontation. As Sarah left the meeting, she reflected on how quickly the situation had changed. 2 weeks ago, she'd been the newcomer trying to fit into an established social structure. Now she was recognized as one of the department's most qualified nurses, with a background that commanded respect from colleagues and physicians alike. But the real victory wasn't personal vindication or professional recognition. It was the change in department culture that was already becoming apparent. Other nurses were standing straighter, speaking up more confidently, and showing less tolerance for unprofessional behavior. Amy had found her voice. Jennifer was more willing to advocate for her patients, and even some of Victoria's former allies were distancing themselves from the toxic dynamics they'd previously supported. The combat medic had accomplished something that years of administrative policies and professional development training had failed to achieve. She demonstrated that competence and integrity could triumph over workplace politics and intimidation. Victoria's reign of terror was over, but the real transformation of City General's emergency department was just beginning. Word of the confrontation spread beyond the emergency department within days. Hospital staff from other units began stopping by to meet the nurse with the military background who'd stood up to Victoria's group. Some shared their own stories of workplace harassment and expressed admiration for Sarah's courage in addressing the situation directly. The administration's response was predictably cautious. While they couldn't ignore the improvement in department morale and the obvious resolution of long-standing interpersonal conflicts, they were nervous about any situation that might create legal liability or negative publicity. Patricia was asked to provide detailed reports about the incident and ongoing monitoring of department dynamics. Dr. Jennifer Walsh, the Emergency Department Medical Director, requested a private meeting with Sarah to discuss her military experience and its relevance to civilian emergency medicine. Dr. Walsh was a former military physician herself and was interested in how combat medical training could be integrated into hospital protocols. "Your assessment of the spinal injury case was textbook combat medicine," Dr. Walsh told Sarah during their meeting. "You identified a high-risk pattern that civilian-trained nurses might miss because they don't see the same volume of traumatic injuries. I'm wondering if you'd be interested in helping develop training protocols for our trauma team." The offer represented both recognition of Sarah's expertise and an opportunity to make a broader impact on patient care. Sarah accepted, eagerly, seeing it as a chance to share the life-saving techniques she'd learned in combat with her civilian colleagues. Victoria's response to her diminished status was to request a transfer to the medical surgical unit, claiming that she wanted to pursue different clinical interests. The request was approved quickly, and her departure removed the last vestige of the toxic culture she'd created. Rebecca and Michael, deprived of their leader and facing a department where bullying was no longer tolerated, adapted their behavior accordingly. Rebecca focused more on clinical excellence and less on social manipulation, while Michael channeled his strategic thinking into legitimate leadership opportunities. The transformation wasn't immediate or complete, but it was unmistakable. The emergency department that had been characterized by fear, manipulation, and artificial hierarchy became a place where clinical competence was valued, professional development was encouraged, and interpersonal conflicts were addressed constructively. Sarah found herself in an unexpected role as an informal mentor to newer nurses and a clinical resource for complex trauma cases. Her military background, once hidden to avoid unwanted attention, became an asset that enhanced the entire department's capabilities. But perhaps the most significant change was in the culture of accountability and respect that emerged from the confrontation. Staff members who had previously accepted workplace harassment as an inevitable part of hospital life began to expect and demand better treatment. The example of one person standing up to entrenched dysfunction had empowered others to voice their own concerns and advocate for positive change. As Sarah finished her shift that Friday evening, she realized she'd found something she'd been searching for since leaving the military, a place where her skills and experience were valued, where she could make a meaningful difference in people's lives, and where professional integrity was more important than political maneuvering. The journey from combat medic to civilian nurse had been challenging, but standing in the emergency department she'd helped transform, Sarah knew she was exactly where she belonged. The battle she'd fought in Afghanistan had prepared her for this different kind of conflict, and the victory she'd achieved would benefit countless patients and colleagues for years to come. Tomorrow would bring new challenges and new opportunities to serve, but tonight, Sarah could take satisfaction in knowing that sometimes one person's courage could change everything. The girl who'd learned to save lives under fire had become a woman who could transform toxic environments through strength, competence, and unwavering integrity. The soldier had become a healer, and in the process, she'd reminded everyone around her what true leadership looked like. 6 months later, City General's emergency department had become unrecognizable from the toxic environment Sarah first encountered. Victoria's transfer had created space for authentic leadership to emerge, and the ripple effects of that single confrontation continued to transform the workplace culture. Amy Peterson had blossomed into a confident, skilled nurse who now mentored newer staff with the same supportive approach Sarah had shown her. Her clinical skills had improved dramatically once she was free from constant criticism and second-guessing. The young woman who had once trembled under Victoria's verbal attacks now led training sessions for incoming nurses. Jennifer Martinez had accepted a promotion to assistant charge nurse, her natural leadership abilities finally recognized without Victoria's interference. She implemented new protocols for addressing workplace conflicts and established a peer support system that prevented the kind of systematic harassment that had characterized the department's past. Dr. Wells approached Sarah one Tuesday morning with unexpected news. The hospital board wants to offer you a position as our new trauma education coordinator. They've been impressed with the training protocols you developed and the improvement in our trauma outcomes since you arrived. The offer represented both professional advancement and official recognition of the expertise that Victoria had tried to diminish. Sarah accepted, knowing that the role would allow her to share her combat medical experience with emergency responders throughout the hospital system. Her first major initiative was implementing a trauma assessment course based on military triage and protocols. The program taught nurses and residents to identify critical injuries quickly and prioritize interventions based on survival probability rather than obvious symptoms. Within 3 months, the department's trauma mortality rate had decreased by 15%. Marcus Thompson, the construction worker whose spinal injury Sarah had correctly diagnosed, made a full recovery after surgery. He stopped by the hospital 6 months later to thank the nurse who had insisted on immediate treatment despite resistance from senior staff. His ability to walk and work normally served as a powerful reminder of why clinical competence mattered more than workplace politics. The changes extended beyond individual success stories. Hospital administration, initially nervous about the confrontation, began to see measurable improvements in department performance. Patient satisfaction scores increased significantly, staff turnover decreased, and physician confidence in nursing assessments improved markedly. Sarah's military background, once hidden to avoid unwanted attention, became a valuable resource for the entire hospital. She consulted on disaster preparedness protocols, trained security staff in medical emergency response, and developed procedures for treating patients during natural disasters or mass casualty events. Rebecca Stone, freed from Victoria's influence, discovered a talent for patient education and advocacy. She channeled her analytical skills into developing discharge planning protocols that reduced readmission rates. Her transformation from workplace bully to patient champion illustrated how toxic leadership could corrupt even well-intentioned professionals. Michael Torres found his niche in emergency preparedness planning, using his strategic thinking abilities to coordinate hospital responses to community crises. His understanding of organizational dynamics, previously used for manipulation, became an asset for legitimate administrative functions. The department's reputation for clinical excellence and positive work environment began attracting top-tier nursing candidates from across the region. New hires were told about the culture of mutual respect and professional development that had replaced the previous atmosphere of fear and competition. Dr. Walsh invited Sarah to present her trauma protocols at the National Emergency Medicine Conference, where her integration of combat medical techniques with civilian hospital procedures received widespread attention. The presentation led to consulting opportunities with other hospitals seeking to improve their trauma programs. Patricia Williams reflected on the transformation during Sarah's annual performance review. "When I hired you, I thought I was getting a competent nurse with military discipline. I had no idea I was bringing in someone who would revolutionize our entire department culture. Your impact has extended far beyond clinical care." Sarah's influence reached into the community as well. She volunteered with local emergency medical services, training paramedics in advanced trauma techniques. Her weekend workshops for first responders became so popular that the fire department requested ongoing partnerships. The monthly department meetings that had once been dominated by Victoria's agenda setting and territorial disputes became collaborative sessions focused on improving patient care and professional development. Staff members contributed ideas freely, knowing their input would be valued rather than dismissed. 1 year after the confrontation that changed everything, the emergency department received the hospital's Excellence in Teamwork Award. During the celebration, Amy approached Sarah with tears in her eyes. "You saved my career before it even started. I was ready to quit nursing because I thought I wasn't good enough. Now I know the problem wasn't my competence, it was the environment." Sarah's journey from combat medic to civilian nurse had come full circle. She had found not just a job, but a calling that allowed her to use every aspect of her training and experience. The skills she'd developed treating wounded soldiers now served trauma patients in downtown Seattle. The leadership abilities she'd learned commanding medical teams now guided department transformation. The woman who had walked into City General Carrying nothing but quiet confidence and a hidden past, had become a recognized leader whose influence extended throughout the medical community. She had proven that individual courage could overcome institutional dysfunction, that clinical competence could triumph over workplace politics, and that authentic leadership could emerge from the most unlikely circumstances. Victoria's departure had created space for positive change, but Sarah's example had shown others how to fill that space constructively. The toxic culture that had driven away talented nurses and compromised patient care had been replaced by an environment where excellence was encouraged, conflicts were addressed honestly, and everyone had the opportunity to contribute their best. Work. As Sarah finished her shift on the anniversary of her first day, she reflected on the unexpected journey that had brought her to this moment. She had come to City General seeking a fresh start, and found instead a chance to make a lasting difference in healthcare delivery and workplace culture. The emergency department that had once been characterized by fear and manipulation now stood as an example of what was possible when talented professionals were free to focus on their shared mission of saving lives and healing communities. The transformation served as proof that sometimes the most powerful weapon against institutional dysfunction was simply one person willing to stand up and refuse to accept the unacceptable. Up next, you've got two more standout stories right on your screen. If this one hit the mark, you won't want to pass these up. Just click and check them out.